Stuart, for the lovely talk. Great to see now more than 500 people online. And the next speaker does not really need introduction. My aim when I was a trainee was always to work with Miss MacNeill, and I managed in the last few months of my training. I was blessed to work with her in the Marsden. And she's a consultant at the Royal Marsden in the London Clinic, past president of ABS, examiner in the European Board of Breast Surgery, and she leads on the GAFT, which is the Get It Right First Time initiative in the UK here, among many other things that this lady has done. So Ms. MacNeill, the next 15-20 minutes are all yours. Thank you.
Lovely. Thank you very much, Yazan. And thank you very much to Ian and Stuart. Those were great talks. Everything you need to know, I think, about neoadjuvant chemotherapy. So I'm going to give what I hope is a slightly practical talk, just reflecting my many years of experience of using neoadjuvant chemotherapy. As a consequence, it's a decidedly non-evidence-based discussion. So I'm really glad to see that you presented all of the evidence so thoroughly there, Stuart, to support response-adapted surgery. Thank you very much. Well, there's no doubt that neoadjuvant chemotherapy can be used as a surgical tool, but it has to be used very cautiously. I do not have any disclosures, but I think the most important thing that I do need to say is that I regularly recommend neoadjuvant chemotherapy to de-escalate the need for radical surgery. So I clearly come to this talk with huge prejudice and bias, but hopefully you'll forgive me. So there are a couple of take-home messages. And the main benefit of neoadjuvant chemotherapy in early operable breast cancer is less radical response-adapted surgery. You'll see many different terms used for this: risk-adapted, response-adapted, de-escalation, less is more, etc., etc. But I think the term that people are now settling on is response-adapted surgery. And I've written here both in the breast and the axilla, because this is absolutely crucial, because an awful lot of what we do see is about response-adapted surgery in the breast, that is converting mastectomy to conservation. But equally important is converting axillary clearance to sentinel node. And as we're all very aware, there seems to be a reluctance to de-escalate surgery in the axilla. So the second message, take-home message, is choose your patients wisely. Biology and response determine feasibility and safety of response-adapted surgery. And this is very clear. And I noticed that quite a lot of the questions on the chat are focused around this. And so it's tumor biology much more than stage. And Ian will, I'm sure, give us more information about this if anybody wants it. But there is a caveat to all of this. And the caveat is beware. Once you embark upon this type of treatment planning, it is complex and it requires the full support and engagement of the multidisciplinary team so you can safely deliver response-adapted surgery. And this is the key, is the safe delivery. So those are my three take-home messages. I'm going to be fairly brief because there's a risk that I could be a little repetitive here. Excuse me, just catch my breath there. So traditionally, neoadjuvant chemotherapy has been used in locally advanced inoperable or inflammatory breast cancer to facilitate surgery for local disease control. But we've really, whilst we still use it for that, we've really moved on from that. And what we're now referring to is the modern use of neoadjuvant chemotherapy to facilitate less radical surgery in early operable, plus or minus node positive, curable breast cancer. And I just wanted to illustrate what I regard as my 3 stages of personal enlightenment over a lifetime of treating patients with breast cancer. And with my oncologist, we started using neoadjuvant chemotherapy way back in the 90s. But it was really in the 2000s, early 2000s, that we started using this on a more regular basis in patients who clearly needed adjuvant chemotherapy. And so we started to use it in the neoadjuvant chemotherapy setting, because I used to do a lot of implant-based reconstruction. And my observation was that patients who had implant-based reconstruction and then went on and had adjuvant chemotherapy had much higher risk of complications in terms of infected seromas and implant rejection. And so with the oncologist, we decided that we could safely give these patients neoadjuvant chemotherapy to facilitate their reconstructive process. Then in 2011, I was looking through all of my old slides, and I gave my first talk on neoadjuvant chemotherapy as a surgical tool to facilitate less radical surgery in 2011 to the Mammary Fold, the ABS trainees group. And as Stuart has very eloquently said, in 2021, 2022, really the question we now need to be asking is, do exceptional responders actually even require surgery? Because increasingly we now have the tools, or certainly we're exploring those, to establish patients who've already had a complete pathological response and therefore may not benefit from any further surgery. So I recommend neoadjuvant chemotherapy. If the biology and stage predict chemotherapy, I then recommend neoadjuvant chemotherapy. And the main reason is it's never been not shown to have a survival disadvantage. And we already know that radical surgery in the breast or the axilla has never shown a survival advantage, because surgery is local therapy. And as we have already seen very clearly, surgery reduces tumor burden, tumor volume, tumor size, it downsizes, downstages. And so it can safely support less radical surgery in the breast and the axilla in selected patients. And this is really a plea for de-escalating surgery after neoadjuvant chemotherapy. The use of neoadjuvant chemotherapy is increasing. We all know that. Neoadjuvant chemotherapy is recommended for most triple negative or HER2 positive cancers now, as Ian has already told us with the recent ASCO pronouncement. There are now very sound reasons for doing this. 35% of breast cancers are triple negative or HER2 positive. And with PCR rates of over 60% now common, we have to take action. Otherwise, we lose this main surgical benefit of neoadjuvant chemotherapy. And I would just put it to you that in 5 years' time, do you still want to be saying, great news, Ms. Smith, your breast and your lymph nodes are all normal, but sorry about the fact you've got lymphedema. So what are the surgical benefits of chemotherapy? Well, there are myriad benefits potentially to chemotherapy. I'm just going to focus on the surgical ones here. So the surgical benefits are that it can facilitate both breast and axillary conservation. We can do less mastectomies, and we've seen that in the evidence Stuart presented. If we do less mastectomies, that means there's less need for reconstruction. If we do less reconstruction, that means there's less need for bilateral mastectomies. And some of you may be aware that in the States, in other European countries there, as the reconstruction rates increase, the bilateral mastectomy rates increase. And this is a very undesirable position we find ourselves in. We can improve breast conserving cosmesis for patients who are already conservable, because we're taking away less breast volume. And we know from some of the very early work done in Nottingham in the 80s and 90s that the less volume you remove from the breast, the better the cosmesis and the better the patient satisfaction. This will also allow less complex oncoplastic techniques. So you can do a simple round block repair instead of a LICAP flap, for example, extended oncoplastic conservation. Also, there's less repeat surgery for positive margins. We don't really have time to talk about this, but that's quite an important gain as well, because as you know, 20% of patients have to come back for repeat surgery for positive margins. And I think crucially, there's less axillary and upper limb morbidity and less chronic pain. But another factor that I find as a surgeon really useful for neoadjuvant chemotherapy, it's perhaps a slightly softer benefit, but it gives time, it gives the surgeon time and the patient time and the team time for reflection on the diagnosis and treatment choices. It gives time for reconstruction planning, which can be very complex. It gives time for genetic testing if this is required, and it gives time for fertility management if this is required by some of our younger patients. So how can we deliver safe response-adapted surgery after neoadjuvant chemotherapy? Well, it starts in the diagnostic clinic, and as you've heard already, and I don't apologise for repeating this, it all is down to patient selection and biology selection. So if you feel that it's appropriate because you have the appropriate patient who's interested in response-adapted surgery and they have the appropriate disease biology and stage, discuss neoadjuvant chemotherapy and potential for risk-adapted surgery from diagnosis. But I think we also have to remember that not everybody is suitable for response-adapted surgery. Some women just need a mastectomy and an axillary clearance. Now that may change over the next decade, but for the moment, some women just need a mastectomy and an axillary clearance, and we have to be honest and upfront with these patients, and we have to manage their expectations, and we'll talk about this a little later on. Multidisciplinary team working, as you've already heard, is crucial to this. Everybody within the team needs to be signed up to response-adapted surgery, to the same goals. And once again, patient selection and biology is crucial. You need to clearly establish disease extent. You need to understand the phenotype-dependent response rates, as Ian has showed us earlier on. And you also need to understand the response patterns and how these might influence your ability to deliver less surgery. And everybody in the multidisciplinary team must understand what the surgical goals of neoadjuvant chemotherapy are. These must be transparent. Are you going to go for standard surgery after neoadjuvant chemotherapy, or is your goal response-adapted surgery? And I think a very important point that we don't discuss very much is that surgery and radiotherapy are both local therapies and they go hand in hand. And it's really important, if you're planning response-adapted surgery, that you must upfront also have a discussion with the radiation oncologists, because what you do not want to do is de-escalate surgery and then overcompensate with more radical radiotherapy. And team communication and team goals are absolutely essential here. And also documentation is crucial. You need to document what surgery is required at diagnosis and what surgery you're aiming for post-neoadjuvant chemotherapy. This is important for consistent messaging throughout the patient's journey. What you do not want to happen is for the patient to get conflicting messages, because this can be extremely difficult to salvage for you as the surgeon at the end. And this brings me to patient engagement and shared decision-making. If it's very clear they need a mastectomy, tell them they need a mastectomy. If it's very clear that they want a mastectomy, then you need to work with the patient to understand why. And if it's very clear that this is going to be their ultimate decision, then I think you should work with them to deliver a mastectomy. So understand their surgery preferences and goals. Post-neoadjuvant surgery will always be appropriate, disease appropriate, but you can explain it might take 2 operations. What I find is patients are often worried, well, what if you don't get rid of all of my cancer? And I can always say to them very confidently, if there's any hint of that, then we will fall back to what we feel is the best surgery for them. And that may take 2 operations, but you can at least take a staged approach if there's some uncertainty. You've got to be honest about the uncertainties of the long-term outcomes of response-adapted surgery. But we also have to be honest about the rapidly accruing indirect safety evidence in well-selected patients. And equally, we as surgeons need to remember that radical surgery does not improve survival for these patients. So although they've got early operable breast cancer, these patients still have, for example, the node-positive patients, a significant risk of systemic relapse. And something that we can always discuss is that future local relapse can always be managed with future local surgery. And this is unlikely to impact on surgery, because for the majority of these patients, as Ian has already shown us, it's their systemic relapse that is going to be the greater risk. And of course, there are undoubted benefits, particularly in reducing the risk of upper limb morbidity. So I keep on talking about managing expectations, but this just bears on my experience over the last few years about the consistent messaging and information through the pathway, because the patients meet numerous individuals and it's not always transparent that your goal may be surgical conservation or your goal may always be mastectomy. And if the patients are then told, great news, your cancer's gone, you can have conservation, when actually they've got 10 centimeters of DCIS and you've always been considering a mastectomy, that's a really difficult situation to salvage. It's especially important if PCR and less surgery, this consistent messaging, if PCR or less surgery is not expected. And increasingly what I found over the years, coming back to tumour biology, is that ER-rich tumours, as you all know, do not tend to achieve the same pathological response rates. But it's really important that patients understand that may not have a prognostic significance, but it's certainly a driver, for example, a mastectomy rather than achieving response-adapted surgery. And once again, you need to be aware of this and be able to give nuanced discussions. And of course, there are some patients, as I've said before, who just need mastectomies. This slide is just to illustrate some of the timelines, and these timelines are quite lengthy, but it illustrates why you do have time to make complex reconstruction planning, for example, because the whole journey between diagnosis and decision for neoadjuvant chemotherapy, final radiology assessment, and then delivering the response-adapted or standard surgery can be 8 to 9 months. So it's a significant period of time, and patients need to be aware of that, because I find patients tend to be quite frightened, assuming that their disease is untreated and trying to explain that chemotherapy treats systemic disease and local disease as well. And as somebody mentioned in one of the questions, this is why patient selection is so important, because if you do not predict a good response, you're not going to give neoadjuvant chemotherapy. Now, coming back to your multidisciplinary team, you really do need to love your radiologist. Obviously, you should love everybody in your team, but you particularly need to focus on your radiologist, because they're the key for unlocking safe neoadjuvant chemotherapy. So at diagnosis, it's really important you get very accurate assessment of disease extent. However, you must not overstage. And this is one of the difficulties. I often find myself saying to the pathologist and the radiologist, look, you've got to look hard, but I don't want you to look too hard. Because we've got to bear in mind there's a significant risk of overstaging these patients, particularly if you use MRI. And I do note that there is an increasing trend to use MRI, particularly for patients having neoadjuvant chemotherapy. Just so you're aware, our standard policy at the Marsden is only to use MRI if they meet the MRI national guidelines. We don't use it as standard for a patient just because they're having neoadjuvant chemotherapy. Our standard is mammogram and ultrasound. But obviously, if we have mammogram occult disease or ultrasound occult disease, or the disease seems to be larger than imaging suggests, then we would use MRI. We do use neoadjuvant chemotherapy for lobular cancer, but in general, those patients are advised that they're unlikely to be suitable for response-adapted surgery. And so we're usually using neoadjuvant chemotherapy in those patients, as we feel it gives them other advantages. So standard breast assessment, establish unifocality and multicentricity. This is important. And as you've already heard, microcalcs do not assume they're DCIS. So you may need to do multiple biopsies. So the diagnostic pathway can be a little prolonged and can require multiple biopsies. And you need to hold the patient's hand throughout this, because this can be quite difficult and a little bit of a seesaw for them. So they need to be well supported. And in the axilla, it's important that you document the number of abnormal lymph nodes, and normally we say more than 4 lymph nodes or less than 4 lymph nodes, because we tend to see that as a prognostic watershed, and also the levels, level 1, 2, 3, so on and so forth. And before chemotherapy, you need to mark the disease location in the breast and in the axilla. No, we don't mark every single lymph node. We put a marker in the dominant axillary lymph node currently, and clearly our practice has changed significantly over the intervening years, but currently we're exploring MagSeed, and so far I've been extremely pleased with these, as they do make finding the lymph nodes post-neoadjuvant chemotherapy much easier. But there's a variety of different markers that you can use. During neoadjuvant chemotherapy, you need to monitor disease response. We normally do this clinically, but we'll usually do 1 ultrasound round about 2nd or 3rd cycle of chemotherapy, just to make sure that the patients are responding. And of course, you've got to have a low threshold for bailing out of chemotherapy, neoadjuvant chemotherapy, if patients are not responding, or for changing the chemotherapy regimen. But in reality, this rarely happens. At the end of neoadjuvant chemotherapy, you need to define and predict the type of disease response with clinical examination, imaging, and pathology. Final imaging is essential, and a clinical examination is insufficient if you're planning response-adapted surgery. And Stuart brought up the early Marsden trials in neoadjuvant chemotherapy, and they had relatively high rates of local regional relapse, and that is because in those days clinical exam was all the patient had. They did not have the more sophisticated final neoadjuvant imaging that we now use to help us plan more accurate surgery. So we use the same diagnostic imaging modalities, mammogram and ultrasound, only MRI if we used it at the beginning, and we need to document the response. With the imaging residual, you need to be aware that it may not represent active disease. And this is important when you're discussing with the patients, because sometimes with sequential scans, they can get disappointed if they don't see sequential size reduction. And this is because we're just seeing scar tissue. And it is a little frustrating sometimes when radiology reports say residual disease. And I think that's an assumption, and we need to get away from that sort of reporting. It is not necessarily residual disease. It is just an imaging residual, and it's not necessarily residual disease. So at the end, your imaging residual must be biopsied, and we now use vacuum-assisted biopsy. We've been doing this now for about 5 or 6 years, and you saw the paper that Stuart referred to presented by Marios Tsoulis with the pooled analysis with Saul and the MD Anderson. So we now use vacuum-assisted biopsy to establish or try to predict the pathological response as well as the imaging response. And then this allows us to plan our response-adapted surgery. Now, it's really important that you do understand all the different types of response that you might see. Clearly, response depends on tumor biology and heterogeneity. I've tried to illustrate this here. So you've got no or minimal response. In general, if you get no or minimal response, this suggests poor patient selection. Type 2 response, this is my definition or categorization. I don't think you'll find this anywhere. This is the patchy response. You'll see it described as Swiss cheese, honeycomb, scattergun. It's normally in the hormone receptor positive patients that you tend to see this type of response. In patients who've got very heterogeneous disease, this is the sort of response you see. And as you can see, they still have the same footprint. So these patients are likely to still require the operation that you thought they would require at diagnosis. But there is another group of patients, and these are the ones whose disease shrinks and you get a smaller footprint. And this allows you to do a small operation. You've got the type 1 response, where you get this implosive type of response where the tumor seems to infold on itself. And these are usually the triple negative HER2 positive cancers. And of course, then you've got the complete pathological response patients, and these are the HER2 triple negative cancers as well. So just briefly, how to perform response-adapted surgery. I quite agree with Stuart that it's really important you understand the surgical definition of pathological complete response rate. There are many definitions out there, but some of them are not surgical because they don't refer to in situ disease. And when you're talking about surgical de-escalation, you cannot be leaving in situ disease in a patient who may have an otherwise excellent prognosis, because that disease will manifest itself over the next 5 or 10 years. So it's really important that you're looking at no residual invasive and in situ disease, and I cannot emphasize that enough. Don't forget your surgical oncological principles. They're always there and they must be followed, even with response-adapted surgery. You need to achieve clear margins. And this requires you to love your pathologist, just in case any pathologists are feeling a bit unloved at the moment, because they'll tell you that pathological assessment of the surgical specimen after neoadjuvant chemotherapy is incredibly challenging. And you need to work with them very carefully so that they understand what you need to know. And of course, if there's macroscopic axillary disease on a positive sentinel lymph node biopsy after neoadjuvant chemotherapy, you either need to clear that axilla or you need to put them into trials, because we still don't know how to treat these patients. And always remember that staged surgery post-neoadjuvant chemotherapy is a possibility, and it will ensure safety if you're not entirely sure whether the patient can safely have response-adapted surgery. You can always try response-adapted surgery and then proceed to extended surgery as required. So what we do is if they've had poor breast response after neoadjuvant chemotherapy, in essence, these patients have a poor prognosis generally, not always. It may just be inappropriate selection or ER-rich disease, but generally surgery is required, as was deemed to be necessary at diagnosis for good local disease control. But if they've got a good imaging response, then we proceed to vacuum-assisted biopsy. And increasingly what we're doing is moving to vacuum-assisted excision. And this is us preparing to set up a no surgery trial for exceptional responders. And we actually remove the imaging residual. Now we can only do this, of course, if there's not extensive microcalcifications. But if a vacuum-assisted biopsy shows residual disease and they're hormone receptor positive, we do tend to recommend standard surgery as was required at diagnosis. But some patients really want to have risk-adapted surgery, avoid a mastectomy, and then we'll do a planned 2-stage response-adapted operation. But for the triple negative and HER2 positive, we'll do a standard wide local excision to remove the imaging residual. We won't remove the footprint, we'll just be removing the imaging residual. And of course, if our VAB or VAE reveals a complete pathological response, then in essence, we're just carrying out a very limited wide local excision. And the main purpose of this is to confirm or refute pathological complete response rate. And as you know from some of the data that we have published, we have high predictive rates for triple negative and HER2 3+ positive patients. I'm not going to say much about microcalcifications because I think Stuart has very elegantly discussed that. But remember, not all microcalcifications are malignant. They must be biopsied, ideally before you embark on the chemotherapy, less ideally afterwards. Microcalcifications, as you know, are associated with DCIS or invasive disease, and they do not generally disappear. So they're very poor predictors of disease response. But if you leave them behind in a breast after response-adapted surgery, then it complicates mammographic follow-up. And this is why, once again, it's really important you work with your radiology team, because then these patients can be subjected to multiple unnecessary biopsies in their longer-term follow-up, which is not good for anybody. So DCIS, all DCIS is chemo-resistant. Well, I think now we know that this is a myth. Urban myth. DCIS is as heterogeneous as invasive disease, and it's biology, as always, that matters. And we're seeing increasing responses in DCIS. And why is this? Well, 25% of DCIS is HER2 positive, ER negative. It's normally the high-grade DCIS, and it's just as sensitive to chemotherapy and Herceptin as is invasive disease. So the reality is response-adapted surgery is positive. It is possible for a patient with extensive DCIS, but exactly as Stuart said, caution is required, as not all DCIS is associated with microcalcifications, and so your assessment may underrepresent disease extent, so do be cautious with these patients. Just to illustrate a patient, this is a young woman who, as you can see, had extensive disease with extensive microcalcifications. She wanted breast conservation. I was deeply unhappy about doing breast conservation. I wanted to do a mastectomy. She was, I think, only 29. She had a very good imaging response to her chemotherapy, but I was not happy just to remove the imaging residuum because of all the extensive microcalcifications. And so I actually did, as you can see here, an extended wide local excision to remove all of the microcalcifications. And this lady had a complete pathological response in her 7 centimeters of DCIS. So just to illustrate what we were saying. So response-adapted axillary conservation. I know you've obviously discussed axillary surgery in some detail in the past, so I'm sorry if I'm repeating anything, but you're all aware that axillary PCR rates are similar, if not higher, to breast PCR rates, and this is probably because of clonal selection, of course, in the axilla. And there's a lot more to gain for patients' perspective from having axillary conservation than breast conservation, because there's often functional gains to be had. But obviously the safety data is more limited in the axilla. So the clinically node negative patients at presentation, We offer them sentinel lymph node biopsy after neoadjuvant chemotherapy. And you may feel this is not relevant to this talk, but I really just wanted to emphasize that I think that sentinel lymph node biopsy after neoadjuvant chemotherapy is now feasible and safe. And I'm not going to go through the evidence, you've obviously looked at it, and there's loads of evidence that it is safe and it's a reasonable thing to do. For these patients, we just use isotope localization, and sentinel node is really just to confirm or refute that they've got a complete pathological response. We normally do interoperative assessment, but this is clearly optional depending. I'm not going to go through the evidence. This is depending on your local facilities. So the more important group are the clinically node positive patients who convert to clinically node negative after neoadjuvant chemotherapy. And for these patients, we use sentinel lymph node biopsy and targeted axillary dissection TAD to minimize false negative rates. And we, as you've already seen, we put in a MAGSeed marker to the dominant axillary node. If we get a good response, we feel they're suitable for sentinel node and TAD. We use dual mapping, we use MAGSeed and isotope. We don't use blue dye as part of our standard sentinel node mapping, so we don't use it at all. And we aim to take out 3 or 4 lymph nodes, including the marked node. And once again, we do full pathology assessment. We do a mixture of interoperative assessment and standard H&E assessment, particularly to look at the presence of scarring. And this is just to illustrate. Here you can see a node that has been clipped, a very abnormal round looking node. The markers being inserted in the second picture. Then the red arrow shows how the lymph node has shrunk with the marker lying in the middle. And then here you can see the excised lymph node with a couple of other lymph nodes with the marker clip in situ. So this is sentinel lymph node biopsy and targeted axillary dissection. This was pre-MAGSeed use. I feel you've got little to lose in terms of attempting sentinel lymph node biopsy and targeted axillary dissection in these women who've got a good axillary response on imaging, because you can always convert to axillary clearance if required. If you don't get more than 3 nodes, if you can't localize, if the sentinel node is positive, you can always resort to axillary clearance. But you can spare up to 50% of women who were node positive at the start of their journey from the completion axillary clearance. So the future is definitely no surgery in exceptional responders. And I'm not going to talk a lot about this. This is a whole separate talk, and Stuart's already given you some information. But the challenge is to reliably and accurately identify these patients who've had a PCR without surgery, because increasingly the role of surgery is now simply to confirm that a patient has had PCR, because we're now so good at selecting patients for neoadjuvant chemotherapy. And this is just some of the papers that have already been published that Stuart has told you about. So take-home messages. Main benefit of neoadjuvant chemotherapy is response-adapted surgery. But remember, you have to choose your patients wisely. All depends on biology and predicted response. But beware, there are many pitfalls in this, and it requires complex planning, and it requires complete engagement of the whole team. So thank you very much for listening to my talk, and always consider response-adapted surgery wherever possible. Thank you.
Many thanks, Ms. MacNeill. It's a great talk, and